Welcome to The Explainer. Today, we're diving deep into one of the most critical areas in nursing. We're talking clinical nutrition. We're going to build from the ground up, from basic metabolic states all the way to complex feeding interventions, giving you a clear blueprint for the bedside and for your exams. So, let's kick things off with a really important mindset shift. We have to stop thinking of nutrition as just food. It's not. It's a powerful form of medication. The right diet can literally speed up healing, but the wrong one can cause serious, serious harm. Every single nutritional choice we make is a form of medical therapy. At its core, the body is pretty much always in one of two states. You've got anabolism, that's the building up phase. The body has enough protein to repair tissues and heal, that gives you a positive nitrogen balance. Then there's the flip side, catabolism. This is a destructive breaking down state that we see in really sick or trauma patients, and it leads to a negative nitrogen balance. Our entire goal with nutritional support is to flip that switch from catabolism back to anabolism. So here's our game plan. We'll start with how to assess a patient's status. Then we'll get into airway safety, which is huge. From there, we'll move into enteral and parenteral feeding, touch on some key therapeutic diets, and then wrap it all up with a high-yield summary of what you absolutely have to know. So let's get right into our first section. How do we actually know if our nutritional plan is working? Well, the answer is in the patient's labs. They're like these crucial signals the body sends us.
The best way to think about these two labs is to picture them as runners. Albumin, it's a marathoner. Its half-life is 21 days, so it tells us about a patient's nutrition over the last few weeks. It's the long story. But prealbumin, that's a sprinter. With just a 2-day half-life, it gives us a snapshot of the patient's current nutritional status. It tells us how they're responding to our therapy right now. That's why, for day-to-day monitoring, prealbumin is always our go-to.
Okay, now we're shifting to a massive safety issue. When a patient has dysphagia, difficulty swallowing, our top priority instantly changes. It's no longer just about nutrition. It's about protecting that airway at all costs. And the biggest, scariest danger here is something called silent aspiration. This happens a lot after a stroke or other neurological injury. Food or liquid goes down the wrong pipe into the lungs, but because of nerve damage, that cough reflex is just gone. The patient shows no sign of distress. We have to be detectives, looking for those really subtle cues, like a gurgly voice or new onset drooling. So how do we feed these patients safely? It's all about a super precise protocol. First off, positioning is everything. Get that patient sitting bolt upright a full 90 degrees. Next, we cue the chin down or chin tuck maneuver, which mechanically helps to narrow the opening to the airway. We also want to place food on the strong side of their mouth, and of course, we only use the thickened liquids prescribed by the speech-language pathologist. Finally, after the meal, we keep them upright for at least 30 minutes. Let gravity do its work.
Okay, so what if the patient can't swallow at all, but their GI tract is working just fine? Well, that's our cue to move to enteral nutrition, using a feeding tube. And listen, when we're dealing with these tubes, there are some absolute, non-negotiable, never-ever rules. The old method of pushing in a little air and listening with a stethoscope, it's outdated, it's dangerous, and it has led to fatal outcomes. The only, and I mean only way to confirm initial placement is with an X-ray, period. And we never reinsert a stylet or add dye to the formula. These are also known to cause severe, preventable harm.
Now, this is an area where practice has changed in a big way. We used to stop tube feedings for much smaller gastric residual volumes, or GRVs. And what happened? Patients were being chronically underfed. The new evidence-based guideline is clear. You do not stop the feeding for a residual under 500 milliliters unless that patient is showing clear signs of intolerance, like abdominal pain, distension, or vomiting. All right, let's escalate to the highest level of nutritional support we have, parenteral nutrition, or TPN. This is our lifeline when the gut is completely out of commission. We have to bypass it entirely and feed the patient directly through a central IV line. One of the biggest dangers with TPN is refeeding syndrome. Let's trace this deadly chain reaction. A patient's body has been in a starvation state. Then we start this super rich TPN formula. What happens? Bam, a massive insulin surge. And what does insulin do? It shoves key electrolytes, potassium, phosphate, and magnesium, out of the bloodstream and into the cells. This sudden drop in the blood can trigger fatal cardiac dysrhythmias. It is a deadly sequence we have to prevent. So managing these massive metabolic risks requires some super strict rules. Because TPN is packed with sugar, we have to check blood glucose constantly.
If an infusion falls behind schedule, we never ever speed it up to catch up. That can cause severe hyperglycemia and dehydration. And because the patient's body is pumping out tons of insulin to handle the TPN, we can't just stop it cold turkey. You have to taper it down slowly. Now, if a bag runs dry unexpectedly, your immediate priority action is to hang a bag of 10% dextrose. This prevents a sudden, dangerous hyperglycemic crash. Another major risk with any central line is an air embolism. If you suspect this, your response has to be immediate and precise. First, stop the infusion. Then, position the patient on their left side with their head down. This is the left lateral decubitus position, and it traps the air bubble in the right ventricle, keeping it from getting to the lungs. Have them bear down like they're having a bowel movement and call for help immediately. Okay, so we've covered the how of delivering nutrition. Now let's talk about the what. This is medical nutrition therapy, where we prescribe very specific diets to treat very specific diseases. Let's run through some key examples. For peptic ulcer disease, it's all about avoiding things that trigger acid, like caffeine and spicy foods. For celiac disease, it's a strict, lifelong avoidance of all gluten. That's wheat, rye, and barley. Now here's a really important one for diverticulitis. During an acute flare-up, the bowel's inflamed and needs to rest, so the diet is low fiber. But for chronic, long-term management, the goal is actually a high-fiber diet. That difference is a classic exam trap, so make sure you know it. All right, we have covered a ton of ground. Let's boil it all down to the absolute must-know high-yield points for your exams and, more importantly, for your practice. Here it is, your final blueprint. For dysphagia, it's all about airway protection, 90 degrees upright, chin down, and thickened liquids. For enteral tubes, safety first. X-ray is the only way to confirm placement, and a GRV under 500 without symptoms is okay. For TPN, you have to prevent metabolic chaos, manage that hyperglycemia, always taper off, and have D10W ready to go. And for medical nutrition therapy, know those disease-specific diets cold. So I'll leave you with this final thought. You walk into your patient's room, the TPN bag is empty, and you find out the next bag is delayed from the pharmacy. What is the one thing you must do right now to save your patient from a completely preventable crisis? This isn't just some test question. This is the kind of critical thinking that defines safe, excellent nursing practice.